Hello and welcome to my video on milk alkali syndrome. The milk alkali syndrome is an interesting syndrome where I think in learning about this you can sort of revise some of the kidney functions. So where does it all start? Well, it starts with milk, although not quite, because usually patients get it from really large doses of calcium and milk isn't quite enough. So they have large doses of those calcium tablets and end up with hypercalcemia. Or it's when they have problems suppressing calcitriol, which is the active vitamin D3, because vitamin D3 has a function in our body that it increases absorption of calcium. So in the normal person, if we have too much calcium, then we would suppress vitamin D3 so that we are not absorbing so much and don't end up with hypercalcemia. But some people don't. So either way, we have too much calcium and end up with hypercalcemia. What happens with hypercalcemia? Well, there's the classical symptoms of hypercalcemia, like the painful bones, renal stones, abdominal groans, and psychic moans, but that's not what I'm gonna talk about in this video. I'm gonna talk about its effect in the kidney, mainly. So let's draw a diagram of the kidney to start with. You have the glomerulus. This is the afferent arteriole and the efferent arteriole. You have the Bowman's capsule. And then you have the proximal convoluted tubule, get loop of Henle, and the distal convoluted tubule, and the collecting duct. Okay, so how does hypercalcemia affect these different parts of the kidney? In the glomerulus, hypercalcemia causes constriction of smooth muscle. So what happens is there's less blood going into this glomerulus, and quite naturally, there's less of the filtrate going into the tubules. So you have decreased in glomerular filtration rate. There's just less liquid in this tubule now. So how does it affect the acid-base balance? Well, because you have less glomerular filtration rate, quite literally, there's less of the bicarbonate going into the tubules from our blood. So we have bicarbonate retention. They just stay in the blood because they never got to the tubule. Also, decreased glomerular filtration rate has an effect on our proximal tubule to increase sodium and bicarbonate resorption. So it also acts on our proximal tubule. Hypercalcemia also has an action on our loop of Henle. The action of calcium on the thick ascending loop of Henle is that they activate calcium sensing receptors. And these calcium sensing receptors have a function of inhibiting the sodium, potassium, and chloride cotransporter. So when you have too much calcium, you have lots of activation on the calcium sensing receptor, and you end up inhibiting a lot of these. What happens when you inhibit the sodium potassium chloride cotransporter? Well, this cotransporter is supposed to help your body reabsorb sodium into the blood from the tubules. But then, since it's inhibited, you end up with natriuresis, which means peeing out sodium because the sodium just stays around in the tubule. And remember, so water follows sodium. So when you have decreased sodium, resorption. You also have less water resorption. And this together causes decreased extracellular fluid. You get kind of a hypovolemia. Well, when you have decreased extracellular fluid, your renal angiotensin aldosterone system gets activated. And now, the aldosterone is that it tries to increase sodium resorption by excreting protons, the hydrogen ions, and potassium. So here you are excreting the protons. So you end up with alkalosis. And that's why it's milk alkali syndrome. There's one more effect of calcium on the kidney. The calcium can also work at the collecting duct. And what it does here is that it blocks the ADH-dependent water resorption. So there is less water resorption by ADH. This is also sort of how you get diabetes insipidus from hypercalcemia. And this, in turn, also contributes to decreased extracellular fluid and activation of renal angiotensin aldosterone system. As we have said, aldosterone tries to increase sodium resorption by excreting the hydrogen. So you get alkalosis. So as a revision, we can see that the metabolic alkalosis is happening through several parts of the kidney. First, we have the bicarbonate retention, increased bicarbonate resorption, and also increased hydrogen excretion. So in summary, what happens is we have too much calcium, which acts on the kidney to result in increased bicarbonate retention, increased bicarbonate resorption, and increased proton excretion. And this all results in metabolic alkalosis. But it's not just the hypercalcemia leading to metabolic alkalosis, because this metabolic alkalosis can also reinforce the hypercalcemia, because you also have these pH-sensitive calcium channels in the distal convoluted tubule. So let's draw the kidney tubules again. To the proximal, loop of Henle, distal convoluted, collecting duct. So you also have some pH-sensitive calcium channel here. So when you get metabolic alkalosis, so your pH increase, it actually activates these channels and result in increased calcium resorption. So that's it. I hope you've enjoyed it and that it has helped you to revise some of the kidney physiology. Thank you.